everyone. We're going to get started in just a moment. We're going to give people about 1 more minute to log on to the system, and then we'll get rolling. I see we've got a number of attendees that have joined us already, and we'll just give a moment more so everyone can get organized. All right, I am seeing a critical mass of attendees with us here today, so we'll go ahead and get started because we have a lot to cover. My name is Carrie Nixon, and I want to thank the Medical Society of Virginia for facilitating this webinar and live presentation for you today, and I want to thank Privia for sponsoring this presentation. We are joined today by Dr. Jerry Williamson, who is a board-certified physician, a pediatrician, who has over 30 years of experience both in practicing medicine and in practice administration. So Jerry's going to lend a very valuable perspective to our conversation today. Scott Disch is also joining us. He is the National Practice Leader for Privia Health. Privia is a very large and rapidly growing clinically integrated network with an accountable care organization, certainly in Virginia and growing around the country as well. Again, I'm Carrie Nixon. I am a healthcare attorney and a healthcare policy person and consultant. And we've been spending a lot of time thinking and talking about MACRA these days, so we're hoping to share some good insights with you. So let me talk for a moment about what we're going to cover in today's conversation. I think it's particularly relevant to talk about how we got to where we are today and where we think we're going. I'm also hearing a lot of people say, well, does MACRA really mean anything for me? And we're going to talk a little bit about why you should care about MACRA. As many of you, I'm sure, have come to realize, MACRA can be a very confusing mix of acronyms. And so we're going to talk a little bit about understanding what MACRA is and talk about its alphabet soup. Very importantly, we're also going to cover how can a practice optimize its MACRA performance. This is something that a lot of people aren't really thinking about yet, but we want to get you thinking and talking about that, and we also want to help you develop a long-term MACRA strategy. So switching to the next slide here, this is a picture that might resonate with some of you. It's kind of a blast from the past. This is Marcus Welby. He was a television physician in a program that aired in the late 60s and early 70s. And the scene that's captured here is how people really envisioned medicine being practiced in days of old, at least. And the doctor sort of at the patient's bedside, really engaging with the patient to figure out their needs and their concerns, and being able to take their time with their patient and have a real relationship with that patient. Things have changed a little bit today, and unfortunately, I think that there are a lot of physicians and healthcare providers out there that would say this picture that I'm showing you right now really resonates. From the physicians that I've been talking with, and from people in the healthcare industry as a whole, there is a lot of feeling of being overwhelmed, of not, of drowning in a sea of terms and policies that they don't really understand, and frankly, they don't really have time to deal with. So, hopefully we'll cut through a little bit of this for you today. I like to think and to talk about where we are today in a very optimistic framework, because I am optimistic about how we can sort of capitalize on healthcare reform and move forward into sort of having a better healthcare system in our country overall. So I want to spend just a moment or two talking with you about the current political landscape. As anyone who has picked up a newspaper anytime in the past, 3 months, 4 months, 5 months has recognized, it's a time of pretty significant uncertainty in the healthcare industry. There's talk of the total repeal of the Affordable Care Act. There's disagreement as to what any kind of replacement should look like. There are many concerns and fears about the direction that healthcare in our country and healthcare reform may be taking. And so, I'm hearing a lot of questions from physicians and from folks in the industry in general as to how does all of this uncertainty play out? And I want to talk about that uncertainty in the context of MACRA, which is the obvious topic of our conversation. Is himself a physician. And Secretary Price, when he was in the House of Representatives as a House member, actually voted for MACRA in the US. MACRA was one of the very few pieces of healthcare legislation that passed in 2015 with bipartisan support. And it passed very much under the radar, I think probably for that reason. It wasn't really necessarily popular to talk about something passing with bipartisan support. But Dr. Price voted for MACRA. He is an advocate for small small doctor practices. He believes that they should have a lot of flexibility in the way that they practice medicine. So, what I want to underscore for you is that although there is a great deal of uncertainty about the fate of the Affordable Care Act and any replacement that may come about, that really doesn't have much of an impact on MACRA, a piece of totally separate legislation that was passed with bipartisan support in 2015. The message to you today is that MACRA is here to stay from all that we can tell. We don't have any indication from Secretary Price himself or from his staff that they're talking about trying to get rid of MACRA altogether. There certainly may be and will be, as we'll talk about, some changes in implementation, perhaps slowing things down a bit. But by and large, we shouldn't look for MACRA to disappear. And that really is because value-based care and value-based payment models are here to stay. The private sector and the public sector agree on that. There is broad bipartisan support for value-based delivery and care mechanisms in general. And very significantly, it's not only Medicare and CMS that are talking about healthcare reform, it's commercial payers who are also being very adamant in their support for value-based models. So, in that context, I think we can all sort of feel secure that MACRA is here to stay, although the devil is always in the details, and there's still some uncertainty as to where the details will shake out. As many of you may have heard, last week, CMS released a new proposed rule on MACRA for 2018. The 2017 final rule came out last October. This is a rule that is being proposed for 2018. It's aiming at providing more flexibility for small practices. That's a big part of some of the changes that the proposed rule makes. This rule, I want to underscore for you though, is really only proposed as of yet. We won't have a final rule until CMS takes all of the comments on the rule into account and issues a final rule a little bit later down the pike. So actually, before I get to that slide, I'm going to take a moment and see who's paying attention here and run a poll. I want to ask you all, how prepared is your practice to implement MACRA's requirements? And you should all now see on your screen a box that has multiple choices for you to respond. It would be really helpful if you all just took a moment for us and responded to this question, because we want to sort of understand how you all on this webinar are feeling about MACRA and how you're approaching it. So let me pause for just a moment. I'll kind of give you the choices here. The first one being MACRA. What's MACRA? And thus far, I'm not seeing anyone say that's the way they feel, but I have certainly been in front of audiences before where people have literally said, what's MACRA? I have no idea what that is. And that's okay, totally understandable. Doctors have much more on their plate to deal with than all of these rules and regulations, but we're gonna tell you a little bit about it today. So I'll give just a moment more. If you're going to respond to the poll, go ahead and do so. And then I'm gonna close it and let you all see the results. Okay, let's take a look at the results here. You all should be able to see this on your screen. We have 11% who are not sure exactly what MACRA is at all. We have 78% that say we're kind of nervous about MACRA, but we're gonna try to do our best. And we have 11% saying we're set and ready to go. So having said that, I'm gonna turn things over to Dr. Williamson and let him talk a little bit about what some other surveys of physicians across the country found. Jerry?
Yes, thanks, Carrie. That survey that I just did with the attendees is not very surprising results. And I think I'm getting some feedback. Are you hearing me as well?
Just a little bit, but I can understand you.
Okay. What is on the slide is the surveys that we've done in January and one in March of this year. I'm not going to go into them, but clinicians, for the most part, don't appear to be ready for MACRA. And I think in part is because of the complexity that physicians are appreciating, as well as other clinicians of this work. Back in October of 14 in 2016, when CMS issued the final rule for the performance year of 2017, the year we're in now, it consisted of approximately 2,400 pages. Now, anything that's take 2,400 pages to explain a rule and implement it is very, very complex. And the complexity of the law resulted, I think, for the most part, in a paralysis for many physicians, particularly physicians that are in small group and individual practices. CMS, though, has been providing some very extensive information, as well as other organizations like the AMA, to assist clinicians in preparing for this transition. However, what I have appreciated in speaking with physicians in a variety of different meetings where I've addressed this subject matter is they're not listening, and they're not listening because the complexity, as I said, has created this paralysis. And they're not ready to establish the necessary infrastructure to be able to succeed. And without that infrastructure, it's going to be very difficult to succeed. Actually, yesterday there was a survey that came out that was a survey from the AMA and KPMG. And they pretty much addressed the same issues, specifically talking about small physician practices were more likely to view the QPP, the quality program reporting requirements, as very burdensome than doctors in larger practices. And they were more likely to say they were not at all prepared for any kind of financial success in the program. For 2017, for the performance year of 2017, 56% of respondents were expected to participate in MIPS. So what we're looking at is we're looking at a complex program. We're looking at a program that physicians in many instances have ignored at this point. But I think it's a doable program. I think it's a doable program if we can approach it intelligently and make it work for us as clinicians. So with that, Carrie, I'm going to drop it back to you.
Yeah, I totally agree, Jerry. So let's talk a little bit now about, if I can make my slides move here. Here we go. Why you sitting here, on this webinar today should care about MACRA? Well, first, we already talked about MACRA passed with bipartisan support. It's pretty much here to stay. And just to underscore, the traditional fee-for-service model really has changed to a more outcomes-based system of reimbursements with both the public sector and the private sector on board. So like I said, I like to sort of present this with an optimistic point of view, and I really view MACRA as an opportunity for physician practices to be rewarded for providing good quality care on a consistent basis, and also to be rewarded for, you know, monitoring and trying to you know, reduce unnecessary costs. That's not to just cut costs in general at the expense of quality, but it's to reduce unnecessary cost. So if you look at MACRA as an opportunity, you see very clearly that you know, there are performance requirements for physicians and for other eligible clinicians that are going to make a difference as to how you do in MACRA. MACRA is going to have an impact on the bottom line for your practice. Your payments or your reimbursement rates are either going to be positively or negatively impacted depending on how you do. And finally, MACRA is going to have an impact on public perception of your practice because these results are going to be published on the physician star ratings. So my message to you today, and I think Jerry and Scott and I all sort of share this as our core message, is that MACRA is an opportunity, and right now is the time to prepare yourself to really get ahead of the curve and to position yourself for success going forward. So actually, before we do this, I'm going to go to another poll real quickly, and I want to see a little bit about the types of practices that are represented on this call. So you all should see another poll right now that says, tell us a bit about your practice. Are you a sole practitioner? Are you in a practice with 5 or fewer physicians? Do you have 15 or fewer physicians? And that number 15 is relevant with respect to the MACRA rule. Do you have more than 15 physicians in your practice? And are you part of a clinically integrated network, or I should say, or an ACO? I think that's cut off. So let me give you just one more moment here. This helps us also to sort of tailor our conversation to the participants here, because we want to make sure we're speaking to all of you and addressing, you know, the various sizes of practices that certainly exist out there. So let me end our poll and share our results. It looks like we have quite a mix here. We have some solo practitioners. We have some, actually a small majority, and with 5 or fewer physicians in their practice. 18% with 15 or fewer physicians, 18% with more than 15 physicians, and 18% are also part of a clinically integrated network or an ACO. Okay, so I'm going to turn it over to Scott right now to talk a little bit about some of these new care delivery and reimbursement models that we're seeing pop up, not only, you know, in MACRA, but with other payers as well.
Thanks, Carrie. I appreciate that. You know, within Privia, we've got kind of a good combination of those same sizes: small solo doctors, some small groups, as well as some very large groups. And we've been able to help kind of bring to them how to be successful in these various shared savings models. I do want to underscore a little bit about what Jerry had said before, too. You've got these 3 programs that historically have been meaningful use: PQRS and the value-based modifier program. And to small practices, it's really been difficult for them to cobble together the reporting and the necessary components within their EHR. And so you saw historically most of the practices failed at about 39 to 42% with those 3 programs. And so it's no surprise that moving forward into MACRA, as we combine them together with cost, that we start to see that CMS is really looking at, wow, we're going to be really hurting the small practices, so let's spend some time and really slow the integration down so that we can make sure we can follow suit and just get some reporting done. So you're seeing CMS signal that we can't go too fast, but we know we're going to be out in 2021, 2022. We're going to be out there, and we need to be progressing providers in their groups accordingly. What we're also seeing outside of CMS is many of the commercial payers are really moving a lot faster. They've been out there. Most of you are familiar with BCPI bundles and CJR bundles if you're a specialist, mostly on the orthopedic side, cardiac side, and occasionally in the general surgery side, although we do see those BCPI bundles in GI where they're interrelating with endo centers and health systems. But you are seeing payers like Aetna or Cigna, for instance, really go further with OBGYNs and look at further maternity models and how we take risk. And they've been doing it for the last 4 or 5 years. You see Care First in the Maryland market, which is a Blue Cross Blue Shield product, really adopting the CPC Plus model or comprehensive primary care model, and looking to actually guide the Maryland market to a single payer. And so you've got in areas where CMS has really seen a particular payer on the commercial side get very creative, there could be some good synergy in the near future around those delivery models and how primary care and specialists get rewarded. So I thought this was very important to highlight. We're going to talk a lot about MACRA today, but we shouldn't lose sight in that the commercials have been out there developing these models for the last 4 to 5 years, and we're seeing now this kind of combination of what the Innovation Center is doing as well as the commercial side of the house.
Perfect. Thanks, Scott. I completely agree here. The commercials really are driving the train just as much, if not more, than Medicare. So the title of our presentation today incorporated alphabet soup, and here's just kind of my fun little visual. You know, we've had reporting requirements, or at least reporting incentives, going back for quite some time now, dating back to, I believe, 2006, which was some of the first reporting incentives. Many of you are familiar with PQRS, the Physician Quality Reporting System, Meaningful Use, MU, the Value-Based Payment Modifier, and now, of course, MIPS. Now, prior to MIPS, we really had piecemeal legislation that did lead to a number of different types of reporting requirements, sometimes that overlapped and that sometimes duplicative, and that caused a lot of frustration for folks. MIPS and MACRA tried to get at some of that by streamlining. But sort of the bottom line with all of these reporting requirements is that in today's healthcare environment, it is not enough to simply say that you provide high quality healthcare. Today, you actually need to report that as well. So let's talk about that for a moment, and this is the main sort of topic of our gathering here today, the quality payment program. So the goal of the QPP, which was established under the MACRA legislation, is to reward quality care through participation in one of 2 tracks. The first is the Merit-Based Incentive Payment System, or MIPS. Many of you have probably heard of that. And the second is in the Advanced Alternative Payment Model track. Now, my suspicion is that most of you on the call today will likely be participating in MIPS, but there may be some of you that are at least close to thinking about participating in the APM track of the quality payment program. And really the overarching goal is to incentivize physicians to be moving toward participation in an advanced alternative payment model. So what we would hope to see is more physicians over time moving from the MIPS track to the advanced alternative payment model track. So let's talk about who it is that participates in MACRA's quality payment program. Well, it's eligible clinicians that participate. And so in 2017, the final rule set forth that clinicians who bill Medicare greater than $30,000 per year, Part B, and, this isn't an or, it's an and provide care for more than 100 Medicare Part B patients per year are subject to MACRA. And those clinicians include physicians, physician assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthesists, and I want to make a note here that there is an exemption for clinicians who are in their first year of practice. The other sort of track of participation in MACRA, as I mentioned, is clinicians who participate in an advanced alternative payment model. And we can talk about that a little more later on. But here's an important note. This is very important. I mentioned to you earlier that last week CMS released a proposed rule for 2018, and that proposed rule increased the participation threshold for eligible clinicians. So instead of clinicians who bill Medicare more than $30,000 per year, they have increased the threshold to say that eligible clinicians include clinicians who have Medicare billings of greater than $90,000 per year, and again it's an and, see greater than 200 Medicare Part B patients. So that's going to decrease the pool, not surprisingly, of eligible clinicians if in fact that the proposed rule, this particular part of the proposed rule, is finalized. So stay tuned, because this could have a pretty significant impact for you if you're billing, say, $50,000 a year. You need to know what that threshold for participation is going to be.
Carrie, I want to tag on to something that you and Scott talked about a little bit earlier, and that's the focus at this point. And I believe that CMS really has a good understanding now in terms of the focus needing to be on individual practitioners and small physician groups. And one of the frustrations that clinicians like myself, and I'm sure many of you that are on the line, have had is that not all of our patients are necessarily of the same acuity and the same intensity. And what CMS has done for year number 2 is proposed a complex patient bonus, providing clinicians 1 to 3 bonus points by adding the average hierarchical condition categories, or HCC, risk score. And the HCC risks, as many of you know, are part of other CMS programs, particularly Part C Medicare. Now, the HCCs are going to be heavily weighted for patients with chronic problems. So the message here, or the takeaway, is that this is all going to be predicated on the greater specificity of your ICD-10 codes that you'll be using for each of your encounters in the outpatient setting. And it's going to reflect the complexity and severity of the patient. So this is now a very critical time to make certain that the ICD-10 codes are specific for those particular patients, to make certain that you're getting the greatest amount of points based on the complexity of your patient population.
Yeah.
So it's something that's important to consider, particularly now, and I guess it's in October, we're going to be looking at a huge volume of new physician codes. So just something to bear in mind.
That's right. Jerry is absolutely right. You know, you need to take advantage of all of the potential bonus points, or you know, maximizing your points for your score as much as you possibly can. And we'll talk a little bit about that more shortly. So as I said before, the goal of MIPS, one of the goals of MIPS was really to streamline reporting requirements. So instead of having separate reporting for VPM, for PQRS, and for meaningful use, 3 different programs, it's all consolidated into one program under MIPS, in MIPS, the quality payment program. So let me run another poll real quickly here and ask, how many of you has your practice participated in PQRS reporting or meaningful use in the past? If you all would respond to that, that would be helpful. And I'll incentivize you by saying that your response may lead to good news. Thank you all for participating in these polls. It's really helpful to us to sort of know where you're coming from, and to keep it all interactive. Okay, so I don't want to take too much time, so I'm going to end it now, and because I think we have a good general sense. And let me share our results. So this is really good news. 80% of you have participated in either PQRS reporting and or meaningful use in the past. And here's my good news message for you. it should not be hard for you to participate in at least a minimal amount of MIPS, in MIPS, if you have participated in one of those programs. You should not have a hard time at all. You can very easily avoid a negative payment adjustment, and you may even be able to benefit from a positive adjustment. So thank you for that. All right, let's move on here. I'm going to turn it over to Scott right now to talk a little bit about the bullet point we talked about earlier, your bottom line, and how these payment adjustments might impact your bottom line. Scott?
Thanks, Carrie. And yeah, definitely on Jerry's bonus point, you've also got points out there, 5 specific points for just being a small practice, for submitting in one of these performance measures. So it's important that you just take action and you can be able to further your score here. You know, we're going to talk about opportunity here on this particular slide, but you definitely want to avoid the particular penalties. What CMS has done in the 2017 ruling is they said, we just need you to start submitting in something to avoid a penalty, right? And so the bare minimum is 3 points to actually get a score of 0. In the proposed 2018 adjustment, that score goes from 3 to 15. And so you can see they're slowly getting much more difficult as they advance throughout the years. What you have here in front of you is just a little snapshot of how these performance years will impact your future. And so each 2-year period of time, in the example on the left from 17 and 18, you will get a score together between those 2 years, and that'll be your 2019 adjustment to your fee schedule. What they are saying is, again, if you're over 3, you're going to be able to avoid penalties. If you don't report at all, will be the maximum penalty of a -4%. And then for those that do report in and have multiple, you can report at different segments. If you're small practices, you can report every 90 days. If you're an ACO, you can report at the end of the year through the typical GPRO process. But they will score you on how well you're doing against the particular standards in play. And then out of 100 points, you will fall somewhere in between that. And that's how they will tell, as they compare your practice to the nation's and their tax IDs, you will get a score on how well you're doing. I'm going to show you in just a little bit about the QRUR report that comes out twice a year. You want to use those particular reports to get an idea of how well your particular practice is doing on quality and costs. So in simple terms, you're going to have these 2-year periods of time. You're going to see how well you're performing and report on how well you're performing, and then CMS will grade you and then give you an adjustment in that following year. So you see 17 and 18 combined for 19. The key to remember is it's going to be compared nationally at this time. There aren't regional benchmarks. The score, one would argue that maybe 50 is going to be the mean. We know that a score of 70 is going to be a top exceptional performer, and I'll share with that in just a minute. But even those that are already on the poll saying, hey, I've done meaningful use, I've done my PQRS reporting before, your scores are probably going to be north of 50, maybe even north of 60. It's how do we do these extra couple of things to make sure we can get into that exceptional bucket based on what you've told us today. And then as you progress out, you see it goes from 4 to 5 to 7 to 9%. One thing to remember that we didn't include here is there's a 3x multiplier on cost or on the actual award that you get. And so what this means is CMS, let's say you get a score of 65. CMS says, great, that's 3%. We're going to give you a 3% adjustment to your fee schedule in 2019. What that will do is set you up for a positive impact on those other groups that might have lost. And so because this is a zero-sum game from CMS's perspective, they're going to pull together all the dollars from all the penalties that have been put out there, put it into a kitty, and then you as a winning provider have an opportunity to tap into those funds at a multiplier of 3x on your score. So in this example, the score of 65, I would get the 3%, but could go up to 9% based on the available funds that are there. Now, there's a lot of debate going on whether those funds are actually going to be there or not. It depends on overall how many losers you have, How many just get a score of 0 or positive adjustments? We're highly believe that in 17, there's going to be a minimal amount of dollars available to grab on that 3x multiplier based on the ramp that they've provided for the providers to get moving to the QPP standards. And so I think future goals in 2018-19 are definitely an opportunity. I put this graphic in front of you, just kind of shows it to you. A median score of 50 and below in this example gives you some sort of negative adjustment, and you see on the positive side, this bar has slid down now to 3 points, as I mentioned, for 2017. And so you just have to submit in one quality measure, one process measure. You know, if you're managing diabetics and you have a diabetic A1C you're measuring, or lipids, and you're tracking those, and you're able to report out from your EHR or your risk registry, that could help you avoid the particular penalties. And so start to think about, if you haven't already, what are the 6 or 8 or 10 things that I do very well as a provider? What are things my staff really understand well managing? If I'm a specialist, maybe it's transitions in care and surgical follow-up. If I'm a primary care physician, it could be hypertension, diabetes, it could be, you know, COPD management. And so there could be ways that you already have data that's available for you to be able to report to CMS. Finally, on this slide, I'd like to make sure we highlight the exceptional performers. If you do get over 70 points, you will have an opportunity with this maximum 10% kitty or pool, the bonus dollars that are going to be available there. There are multiple talks on the Hill right now around shifting some of those dollars to an APM track to incentivize providers to move quicker to an advanced payment model. However, today in the legislation, it's slotted to be under MIPS. And so you will have an opportunity to garner more dollars should you hit above that 70-point threshold. Next slide, please, Carrie. What we did here was put together just a quick dollar amount for you in the early years, and then scale that out to the 5, 7 to 9%. And this is for, you know, a group of 4 non-surgical specialists with a decent revenue there, fee-for-service revenue of $2.2 million, 35% Medicare. So you can see what that nets to just Medicare fee-for-service revenue. And the reason we do this is it's interesting. Providers actually believe it's similar to, like, either I get bonuses or I might just be eligible for a little adjustment. This becomes really a full-time equivalent individual in your practice when you think about the revenue hit that you're going to have to take if you're not participating in this. And so we really encourage you to get on early, start doing some of these activities, because they will make you better for the commercial payers. They will make you better for Medicare Advantage when the all-payer model kicks in. And they will avoid having to make serious cuts to your practice. So be on the upside the earlier you can. Carrie, I think I'll give it over to you to highlight a little bit of the composites within MIPS.
So we're going to dive into the 4 performance categories that make up those over at WellMU, and we may have the opportunity to do another webinar for you all that dives into each of these categories specifically in more detail. So the 4 performance categories are listed here: quality, which you all are very familiar with, clinical practice improvement activities, which is actually a new category, and we'll talk about that in a moment, advancing care information, which really aligns with the Meaningful Use program, and then controlling cost. So let's go ahead, and each one of those categories is scored separately, and they are weighted separately in developing one composite score. We'll talk about that more in a moment, but I want to dive into quality with Dr. Williamson.
Thank you, Carrie. The quality measure, or the quality score, makes up 60%, 60% of the total score. And in fact, in the 2018 proposed rule, they've elected to maintain that 60%, where originally they were thinking about bringing it down to 50%. But the quality category of MIPS will have a very significant impact on clinicians and their organization's MIPS score. You can see on the slide there are 3 examples of some of the quality measures that are available. And they're in excess now of 300 quality measures that you can choose from. And as you can see, it's really not rocket science. We're talking about treating adults with acute sinusitis with the appropriate choice of antibiotic, controlling patients' elevated blood pressures, and looking at A1Cs for our diabetics and maintaining good control for them. Now, I certainly, as a physician, I understand that a lot of this is to a certain extent out of our control in terms of it being within the patient's control. So that's something that I'm cognizant of, and I realize that it will impact some of the scores that we have. But to Scott's point earlier, the measures that you're going to select and the method in which you're going to submit your data is going to have a great bearing on these scores, specifically for quality, on clinician engagement, as well as the administrative costs. And we know as well that the decisions that you're going to make are going to be highly dependent upon electronic medical record capabilities, the resources that you have, the modifications you'll need to make in workflows, the data extraction costs, and other practical realities. Carrie, can we go to the next slide, please? Yeah, the next slide. Choose the quality measures that are most appropriate for your patient population for which you can demonstrate improvement. I can't stress this enough, and I think Scott touched upon this in a previous slide. What makes the most sense for your patient population is where you should be going and identifying where to focus your quality efforts. Submitting measures that maximize the quality score performance points, as well as not just the performance points, but also the bonus points as well. CMS is going to be looking at each individual measure, not all the measures in aggregate. So you need to choose wisely in terms of what measures you're going to be looking at. Not all measures are created equal. And there's something that's a term that's been used entitled measure leverage. And what I mean by measure leverage is basically picking the measures that are going to exceed your benchmarks. And of course, Scott will be talking a little bit about later about the QDR, and as well as what Carrie mentioned earlier, as far as looking at the PQRS scores to see where you were and which items or which quality measures you did well with. And those are the ones that you want to continue. The goal here is to increase your score with limited additional work and limited flow changes in your workflows. Scott, Carrie, do you want to tack on to anything on that?
No, we'll go ahead and move. That was excellent, Jerry. Let's go ahead and move to the clinical practice improvement activities. I suspect people will have quality questions, but we'll move through first.
Okay.
Yep, and in the sake of time, so we have some time for questions, I'll keep moving this one pretty quickly through. The clinical practice improvement activities are really embody a patient-centered medical home. And Jerry, as a pediatrician, understands this very well. It started in pediatrics, adopted AAFP, and NCQA, National Center for Quality Assurance, really has a very solid program on patient-centered activities. This is really what they're looking for you to do. And this is an attestation composite or category. And so really you're going to attest that you're doing these items, very similar to like your security risk assessment under meaningful use. You've got to set up activities on care coordination. So do you have handoffs? Do you have activities of which you get notes back from your specialist? Are you thinking about advanced care planning, things like that? If you are having living will discussions, there are ways that you can attest that you're doing activities and then be able to attest that you're covering that. Beneficiary engagement, activities like, do they access the portal? Do you send them information around their care plan? Do you have that communication set up with them so that you're updating their goals? Population health management. An example would be risk stratified patients. So if you already have a tool or a risk registry that can do this, you don't necessarily only have to go out and buy it. You can do it within your EHR. there's enough information in there clinically that can get you an idea of some of the social determinants of health, of patients that are probably needing more care than others. You could use it with patients who are on Coumadin. Are we thinking about switching in the warfarin? You could be looking at the preventative measures. So there's ways that you can think about clinical practice improvement activities and making sure that the patient feels that the practice is working really on their behalf. So you'll select, there's 90 measures, you'll need to select enough that you can earn up to 40 points. The original rule back in the day was a much larger 60-point rule. They lowered it to 40. And really, these 4 that you attest to, there's either high or medium rankings. And so for the high measures, you get 20 points. For the medium measures, you get 10. And so you really just got to select enough to get 40. So again, just like you'll hear us say with Jerry and I, make sure you're selecting things that relate to the patients you're already seeing. So if you have an asthma and allergy practice, let's think about how we're looking at our corticosteroids, our antibiotic usage. Let's think differently so it's not too far away from what you're comfortable managing. And then really plug in with your patients, and you'll be able to get this particular one as a check off the list.
Perfect.
Jerry, I want to turn it back over to you for advancing care.
Care again, in the interest of time, this will comprise 25% of the MIPS total score in year number 2, and there will continue to be a focus on the secure exchange of health information and the use of certified electronic health record technology to support patient engagement and improve patient quality. One thing to be mindful of is that the recommendation was made to migrate to the certified 2015 edition to take advantage of the improved functionalities that were in that system. But the proposed rule for 2018 is to permit eligible clinicians to continue to use the 2014 edition in performance year 2018. So that's an advantage and doesn't require you to go out and purchase the 2015 edition. Also, there's a proposal in the proposed rule to add a significant hardship exception for MIPS eligible clinicians that are in small practices, and we're waiting to see exactly what that will be. And they'll be proposing some minor changes in objectives and measures that are forthcoming. Turn it back over to oh, that's me. I'm still on there. Okay, good. If you have attested to meaningful use stage 2, you may have already achieved your ACI base points. And that's important because I'm sure many of you have already achieved stage 2. And I want to make an important point here as well. We have, and Scott talked a little bit earlier about attestations. Those of us that have attested to the meaningful use program understand what an attestation is. What we're attesting to is the fact that we've met all the requirements in that program. Falsely attesting to meaningful use resulted in one particular case in Texas, a 23-month prison sentence and a $4.5 million restitution for this particular hospital. And the reason that I bring that up is that the MACRA MIPS program is a condition of payment with CMS. And one will look at this and say, well, in order to avoid a penalty, if I suggest that I'm doing something which in fact I'm not, or in order to achieve an incentive, I'm submitting something and reporting something that I have not done, that potentially can create a problem in terms of fraud. So, and if during the audit they find that you falsely attested, there's certain remedies that the government uses. So you need to be very, very careful in terms of your attestations and what you're submitting in terms of reporting. The reporting has to be accurate. It must be accurate, and if you need some additional staff to assist you with that, that's going to be critical as well.
That's true, Jerry. Those orange jumpsuits are just not a fashion statement.
No.
I did want to kind of marry the two that we were talking about, because let's say you choose patient decision support, right? If you choose decision support, even though it's not one of the 5 in the 2017 or for ACI, if you choose decision support, you could actually satisfy both sections because you're engaging the patient in the clinical practice activities, and then you're also doing that activity in ACI. So again, sharing, you could choose and print some of these off from the Dartmouth. I know Mayo has them, a company called Emmy. You can print off educational materials and give them to the patient. You're engaging them in their care. Again, if they have osteopenia, you're helping them figure out what is the right treatment plan. Should I need surgery or procedure, or do I just go ahead and set up something else that would be better for me?
Terrific.
Looks like.
So we lost Scott's visual for some reason,
Yep.
but he's still be with us. So that's good news. Scott, are you still able to see the slides, or should I take the cost slide?
I can take the cost slides. For some reason, I did lose the visual, which isn't a problem. I'll go ahead and carry the slide since it's up there, not a problem. So what we have here is, I'm going to talk to it briefly since 2017 is not really impacted by cost. And what it looks like in the proposed rules, 2018 will not be either. So we have a little bit of a time. I would, however, encourage us to still stay very vigilant and start analyzing your QR/UR reports. So if you could, the next slide, Carrie, we'll show the picture of the QR/UR. You should be pulling this down from your CMS website. It's on the quality section in there. You should be having an idea of what this looks like for 2015. The 2016 reports are coming out here in July. You should be on that website making sure that either as an office manager or the lead physician, you're pulling that down. And then come mid-year, which is the end of 2017, you'll also get another report. So look for these summertime and end of the year where it's trailing about a year's worth of time. So really, really important, because these are the key reports that CMS is really scoring you on. Even though you'll be at testing and you'll be submitting other information, this will give them how well you're doing on cost measures, episodes of care. We'll also look at quality measures, specifically bundles of quality. So like the acute and chronic composite scores under cost will be measured here. Very, very strong focus on diabetes. So if you're somebody who's a little uncomfortable about diabetic care, make sure you've got your endocrinologist tucked in there with you, because it's really going to matter on how well you're performing there. Your readmission rate will be a measurement out there that they already know. So if you're in an ACO and you don't know what that is, make sure that you have an idea if you're at 11% or if you're really performing poorly at 19%, because that's going to impact you. So it's knowing these sort of activities early, because it is going to matter in the near future as we start to hit performance years 2020, 2021, because we have to get up from 0% today applied to cost to 30%. And so we're just not going to be at 30% overnight, but we do have to start looking at our medical costs and specifically our pharmaceutical costs in the very near future. Carrie, I'll put that back over to you and I'll try to fix the video.
Sure. So let's bring it all together. Cost, the advancing care information category, improvement activities, and quality all come together in various weightings to form your composite performance score. And that is what determines the degree of your payment adjustment. And that's the score that is going to be made visible to the public via the Physician Compare website. In this chart, you see a breakdown of how the categories are weighted in 2017 to get to your overall score. And really the bottom line message here is that the combination of the performance metrics that you choose to report and to pay attention to in this program matters. You have the ability to optimize your composite score by choosing the right metrics for your practice. Choose the metrics that make the most sense. And if you're doing that, you're going to see a higher score, a higher composite score, and you're going to be sort of on the right-hand side of the bell curve, meaning that your performance is going to be on the high end, and therefore your reimbursement is going to be on the high end as well. Let's see, we can talk very quickly about the 2017 transition year, picking your pace. Scott, do you want me to take that, or are you back on track?
No, I can take it. It's perfectly fine. I think the most important thing is, you know, it's got the 3-point threshold. I know Kathy had asked a question earlier about realistically, where do you see the winning side versus the losing side? You know, honestly, they're going to be in percentile differences. So they're going to be, you know, you're in the 10th percentile, you're in the 50th percentile, 70th percentile. That's how they're going to weight your score. And so any score today in 17 over a score of 3 is going to get you a positive, right? Either a point, you know, 0.5%, 2.5%, 3%. It all depends on where that mean actually hits and where you kind of get over that particular element. So we'll see actually how it compares to the nation once all the data's in. But realistically, if you're doing the composite of ACI for meaningful use, you're going to get a point system already in play. Like Jerry had alluded to earlier, if you're in practice on your own, you're going to be able to get 25 points under the ACI measure, 15 points for the attestation medical home measures, and then 60 under quality. If you're in an ACO, that just adjusts to 50 for quality, 30 for ACI, and 20 for CPIA. So you're going to do pretty well as long as you're looking at your particular EHR data, your risk registry data, and submitting in something for CMS to prove that you're tracking it and reporting it. So that's really what the pick your pace is about. It's about you've got this time window to report in 90 days. You can wait to the end of the year, but we recommend that you start looking at your numbers every 90 days to figure out if you can submit in. And the more that you submit in, the more bonus points you get, like we talked about earlier. Small practices get bonuses, HCC coding enhancements get bonuses. There's bonuses for more process measures. They're really trying to help practices start to just aggregate this data much more. Next slide, please, Carrie. And so this underscores if you are going to be eligible for an AAPM, Advanced Alternative Payment Track, CMS will notify you in a letter, just like they sent out the letters this April, where they had said you're an eligible clinician under MIPS. You'll see that under an AAPM, if you are an entity bearing more than 25% risk, which means are your patients in a program like CPC Plus or the oncology care model if you're an oncologist, could be BCPI if you're in a bill payment arrangement. Are your patients actually under a sort of risk deal where you as a provider are financially on the hook in a downside approach? And so that is something to really be thoughtful of. If you're part of an ACO, you have to get an idea of which track are they in. One Plus that just rolled out does qualify. There are other ones in track 2, 3, and next gen that qualify as well. And the Medicare Advantage model will be qualifying in the other payer model in the future years. But if you don't do anything, you're going to get a 0. And so even if you're in an AAPM, you've got to submit in quality. If you're in MIPS, you've got to submit in quality and attest to the measures. So you've got time to start doing it. We really encourage you to step up and start looking at ways and things that are tracking in your practice. And then the final slide, Carrie, is really how do you submit in? Jerry mentioned a little bit about the certifications, the different editions for 2014 and 15. Definitely those are fine for this particular year. Most of the EHRs have qualified under 2014 with some minor exceptions. We won't name those. And then you should be looking into, if you haven't, what's the right clinical registry or risk registry where I can pull this information and aggregate it. They are a little bit expensive, so if you're going to go into a virtual group, which is going to be having an idea in 2018, you want to start to look at what are the pieces that that virtual group that I'm joining might have. If they have a risk registry, they have a clinical registry, I might be able to tap into that, already satisfy my reporting. So you want to really think through how are you going to give this information to CMS. You can give it through a variety of ways. The easiest way is to pull it out of your EHR or a risk registry. Jerry, did you have any comments about reporting there? And then we can kick it back over to Carrie.
Yeah, the only thing that I was going to comment on here, Scott, in terms of reporting mechanism is that I think organizations need to look at the differences in their administrative effort and cost in terms of whether to report individually or report as a group. And if you can figure out a way to configure your 40 or 50 docs, if not, you need to report individually. And understanding as well that the public exposure exists as well in terms of whether it's individual or group, and that some of the high performers may have their score dragged down by those that are low performers. So that, and individual clinicians may not have enough data to report, whereas the group does. And one final caveat on that is in terms of group reporting for quality, they need to report all clinicians in that group, even those who would be excluded if in fact it was reported individually. So when you're reporting quality, it's everybody in your group, whether they are eligible clinicians or not. So that's all I wanted to add, Scott.
Terrific. Thanks, Jerry. So we're not going to spend time right now talking about advanced APM pathways. You all are going to receive this slide deck after the presentation, and so you can take a look at it as need be. Hopefully we'll do another webinar at some point on advanced APMs, and we can really dive into things there. But for right now, I just want to talk about very briefly our key takeaways, and we'll wrap up. As we said before, if you've done any PQRS reporting, if you've done meaningful use, if you have some practice activity your practice is doing, you are very well situated to avoid a negative adjustment to your reimbursement. I've heard a number of physicians just kind of throw up their hands and say, forget it, this is too complicated, I'm not going to do it, I'm just taking the negative 4% hit. That's a really short-sighted perspective because it has long-term implications. It's not just 4% down the road, it ratchets up pretty significantly to affect your reimbursement, and this really is the direction that we're headed. So, if you've done any of this before, you're particularly well situated to start the MIPS program. There's simple things you can do to optimize your score. There's Scott, he's back with us. And the performance metrics that you select do matter. And then finally, as I just alluded to, this is a long-term game, and you really need to start thinking about what's your game plan. You don't have to have all of the answers right now, but you need to think about the direction that your practice is heading and maybe how you might get to an advanced alternative payment model at some point. It can be kind of a complicated thing to think about, but we are happy to sort of help you think through that. There are some tips on how your practice can take advantage of getting started on the path at macraoncall.com. Again, our contact information, my contact information is here. If any of you all have any questions that you would like to ask that we haven't addressed today, please email us at this address, contact@healthcaresolutionsconnection.com, or at my personal email address, which is on my bio at the end of the slides. And I will make sure that both Jerry and Scott have the opportunity to answer your questions as well, because we want to make sure that you leave this presentation with your questions answered. So I'm going to ask you all to do us a big favor and to participate in one final poll before you sign off. And I don't need to show the results or anything like that, but I'm going to go ahead and launch the poll. It's just a feedback poll on how you all enjoyed today's session. It's just a few questions. If you all would submit there, that would be terrific, and we would really appreciate it. We will be sending out a recording of this presentation as well as the actual slide deck itself. Thank you to Dr. Jerry Williamson, to Scott Disch, and to the Medical Society of Virginia and to Privia for putting all of this together. Jerry, Scott, did I miss anything?
Carrie, one quick point. You mentioned about sitting back and taking the 4% hit in that first year. Coming back to what Scott said earlier, and I think it's critical that we mention this, is that this is Medicare. The private payers are already moving in that direction. They were moving in that direction before even Medicare developed this program or CMS developed this program. So even if you take that 4% hit, you need to be aware that your private folks are going to be doing the same thing. And so you may as well be prepared for it.
Good point, Jerry. Thanks. Scott, all set on your end? Oh, now we can't hear Scott.
Yeah, we can't hear Scott.
Now you can hear me. I'm all set.
Good. All right. Thanks, everyone. I'm going to leave this poll open for a moment. We would appreciate it if you would complete it, and then you can sign off. So thanks again. Bye-bye.